Good morning, everyone. Today, our topic of discussion is shock. As in the previous lecture, we had covered fluid and electrolytes, and I told you like the next lecture will be about shock. So, of course, like whenever anyone is in shock and in surgery, especially um, in surgery, in many surgical procedures, many of the patients, they lose a lot of fluids or they lose a lot of blood. Uh, I'm using the word fluid because in many of the um, long surgeries, what happened is like, for example, laparotomy, fluid is also lost. Plus, in many of the traumatic patients, what happens is they they lose a lot of blood, and that can result in hypovolemic shock. And hypovolemic shock is one of the field, you can say, one of the topic which is studied in a great or in too much detail in medicine. So let's start. Of course, we are going to discuss definition and approach to a hypotensive patient, what are the types of shocks, and also we will discuss about the specific treatments which are available. So, shock is defined basically when there is a failure to meet the metabolic demands of the cells and tissues, and the consequences of that, what happens as a result of that thing. So, remember this thing that in shock, what is happening is basically decreased tissue perfusion, or you can say like tissue hypoperfusion. And that, like, due to that, or as a result of that, of course, there is a lot of secondary changes which occur. For example, many of the cellular products are released as a result of endothelial or cellular activation, like what happens in septic shock. Um, as you can see over here, shock can occur with the normal blood pressure, and hypotension can occur without shock. For example, in anaphylaxis. So of course, like these are the name of the different type of shocks which I'm taking right now. When we'll discuss in detail, you would understand what I'm going to say, or what I mean to say this thing. So a shock is a very common cause of death as well, and if resuscitation or the help is not given to the patient, so many of the patients they can die because of organ ischemia, or what you can say like hypoperfusion injuries. So now, of course, in the body there is a lot of physiological responses to shock. For example, there is a lot of neuroendocrine, metabolic, and inflammatory changes which occur due to shock. If you will can see over here, like two main things are given. One is sympathetic nervous system, and one is renin-angiotensin axis. So, like norepinephrine is released, dopamine is released, cortisol is released, which can cause vasoconstriction, which causes vasoconstriction, which uh, make the heart beat faster, increased heart rate, and increased cardiac contractility, as a result of renin-angiotensin aldosterone axis. Due to activation of that, what happens is like the body it started conserving more water and sodium, and also it caused vasoconstriction, which results in increase in blood pressure as well as increase in blood volume. So simply in the shock because the metabolic demands of the cells are not met. So what happens is that in the start there is cellular injury, and in the start basically that cellular injury is somewhat reversible, but if the tissue perfusion is not uh, brought back to normal or near to normal, you can say, or it is prolonged, of course it can result into severe um, changes at the cellular level which can become irreversible. So the basic concept to here to understand is what, like, there are two kind of shocks. One is reversible shock and one is irreversible shock. So simply we don't want anyone, anything, or any patient uh, to reach to that irreversible changes, of course, which cannot be reversed by resuscitation. And remember, like, fluid resuscitation is the backbone, or you can say is the um, mainstay of treatment, to reverse that shock, especially hypovolemic shock. Of course, like in septic shock, antibiotic therapy should be given, uh, and so on. So, in hemorrhagic shock or in hypovolemic shock, of course, fluid resuscitation is the most important thing to be done. So, the important thing here is what um, you can see over here. The goal is to maintain cerebral and cardiac perfusion, vasoconstriction of splenic and musculoskeletal renal blood flow. Okay, and now actually, again, it is going to waste a lot of time if I will start talking about the physiology or to the basics, because you have already done that thing in physiology. But um, as we know that whenever the cells don't get enough oxygen, what they do, like, they switch to the anaerobic metabolism. Like, normally when they are getting the oxygen, so the metabolism which are going on is the aerobic one, as you can see over here. 6 carbon dioxide, 6 water, 36 ATPs are formed and heat is released, right? So this aerobic and anaerobic respiration, see, because what we are concerned, or what we are discussing over here is cellular metabolism, which can only be carried on in the presence of oxygen, and oxygen is delivered by the blood. And like, when there is whenever any patient is in shock, so of course what happens is, like, the blood cannot perfuse the tissues, or you can say the blood cannot perfuse the cells. So what happens is, like, the cells can change into anaerobic respiration or an anaerobic metabolism. So what happens, like, once they switch themselves to anaerobic metabolism, so see, there is no oxygen, glucose is diverted towards the lactic acid pathway, in like simply anaerobic metabolism, like the glucose utilizes 2 lactic acids, 2 ATPs, and in this one you can see 36 ATPs. So see, there's a huge difference. So one thing which can be understood from this one is what, like, whenever someone is in shock, the lactic acid will start forming in it. It can accumulate in the body, in the blood, okay, which can also lead to metabolic acidosis. And once the glucose will be exhausted, again the anaerobic respiration will stop. And once the anaerobic respiration will stop, of course the sodium potassium pumps will be stopped, and the cells will stop functioning. Intracellular lysozymes will be released and they are going to destroy the cells. And potassium, of course, like, cells are the packet of potassium, and the potassium is going to release in the blood, which can result into death even. So this is what happens like in shock. Okay, these are the two much basic things of the shock. So remember hypoxia, acidosis, all these things, they bring a lot of changes in the blood, in the body, like they activate the immune system, the coagulation system, and it can result into the release of oxygen free radicals. Cytokines are released, which can injure the capillary endothelial cells, and again the endothelium is become damaged, and it become leaky, and the fluid will start oozing or coming out from that capillaries, which can result into edema. So all these changes, of course, like will lead to irreversible changes. Of course, after that, the shock cannot be reversed anymore. So a lot of other changes, of course, will happen. For example, there are many cardiovascular changes, like the preload and afterload will be decreased. The heart will go into tachycardia. There will be vasoconstriction, except in sepsis, of course. There is one exception here is sepsis. There are many respiratory changes as well, like increased respiratory rate. There are many renal changes as well. Of course, when the perfusion to the kidney will be reduced, so what will happen that the kidneys are going to uh, activate the renin angiotensin aldosterone axis, and it is going to cause vasoconstriction. It is going to retain more and more sodium, more and more water. So a lot of changes can occur. So see, this thing like is the same things, but like of course I'm just explaining the things in more detail. So remember, the thing which is going on is hypoperfusion, which is causing all this, you can say, vicious circle, or um, all these cascades, which can lead to ultimate cellular death or tissue death or the death of the patient. Um, Now, not just these, of course, like uh, if you know the basics, you would know like what are stretch receptors, what are baroreceptors, what are chemoreceptors, what are the cerebral ischemic responses, what are the vasoconstrictors, and how the fluid shifts or how the kidney responds. So, of course, like we cannot discuss all this thing in one lecture. Like that's why the basics are very important. So simply, it's a vicious circle once there is hyperperfusion, and uh, this reperfusion or ischemia, um, all these things basically lead to a vicious cycle of shock. And of course, like once the body cannot compensate anymore, so there will be cardiovascular collapse or hemodynamic disarrangements, which can lead to its irreversible phase of shock. So now, um, and due to result of that, what can happen is multi-organ dysfunction syndrome can occur. So what is this multi-organ dysfunction syndrome? Of course, in the coming lectures we will be discussing systemic inflammatory response syndrome and multi-organ dysfunction syndrome. So of course, like in that one we are going to talk this thing in more detail. But simply, multi-organ dysfunction is something when two or more than two organs are not functioning well. For example, the heart, the kidneys, the lungs, the blood, and all these things, uh, can lead to, of course, damage to the person. Okay, so I think it's better to tell you the types of the shocks first and then talk more about what happens in each of the category. Okay, so basically there was a big change, in medical science once they started infusing the IV, what you can say, IV fluids or blood products, because before that, anyone who have what you can say who lose or who started losing blood, okay, what happens is was what happened before was like, of course, there was no way to replace that uh, lost blood or lost body fluid. So of course, resuscitation was not that much possible. But nowadays, of course, because we can infuse the patient with the IV fluids or blood products, of course, that the situation is quite changed. So you can see like what are the type of the shocks, or the classification. Okay, the classification is a bit tricky, and many in different books, different type of classifications are written. But okay, I will take the most commonly one which is given. So they classify it as hypovolemic, cardiogenic. Okay, uh, then it could be uh, obstructive. Okay, sorry, obstructive was written. So then it could be distributive. I will tell you why I removed neurogenic and endocrine from this list. Okay, or septic shock from this list, because like basically anaphylaxis or what you can say that septic shock are a type of distributive type of shock. So now hypovolemic shock, again, it's quite simple to understand. What is hypovolemic shock? Whenever someone lose a lot of fluids, or the blood, the circulating volume, in other words, it is called as hypovolemia. So hypovolemic shock is simply when someone have less circulating volume, okay, which could be due to hemorrhage, like someone who is involved in a road traffic accident and started losing blood, or which could be a non-hemorrhagic type of shock. For example, someone who had dehydration due to vomiting and diarrhea, right? Especially in pediatric patients, many patients they die whenever they have gastroenteritis. They like cholera. They have repeated vomitings and diarrhea. So I like this way. So of course, like this is the most common type of shock, okay, and this one is the one which basically occurs whenever someone lose um, the circulating volume. And of course, like whenever like someone lose the blood volume, it depends on how much volume they have reduced, and that's how they classify hypovolemic shock. Of course, there are many compensatory mechanisms like uh, stretch receptors or baroreceptors, which are present in the large arteries. Uh, like they had a lot of what you can say compensatory changes. Okay, so there is sympathetic stimulation as well, release of epinephrine and norepinephrine and angiotensin, aldosterone axis can be active, like will be activated, and all many of the changes are there. Now you can see over here a 68-year-old mother with history of hypertension and diabetes presents to the ER with abrupt onset of diffuse abdominal pain with radiation to his back. The patient is hypotensive, tachycardic, afebrile with cool but dry skin. So now, if you can see over here, this is what you can say a patient who have hypovolemic type of shock. So diabetes mellitus, of course, like there is a lot of urinary loss. Okay, and what happens is like one of the complication is hyperosmolar state. Okay, so what happens in this one? There is hypovolemia. Basically, like the patient is severely dehydrated. So now As I told you, could be non-hemorrhagic and could be hemorrhagic, right? So non-hemorrhagic like vomiting, diarrhea, I give the example, burns, neglect, or environmental like dehydration, or hemorrhagic, again, the patient is bleeding from somewhere, okay? And one of the thing, of course, is called as third spacing. Third spacing is simply like when the body fluids are collecting inside the body, like what happens in pancreatitis or ascites, for example. So now, of course, like okay, I'm going to discuss the managements later. Okay, okay. So that is like about hypovolemic shock. Okay, now hypovolemia is basically it depends on like we grade it like how much blood is lost in emergencies. Like it's either it's grade 1 shock, grade 2 shock, grade 3 shock, or grade 4 shock. Like someone who lose like 40 more than 40% of the circulating volume. Remember the circulating volume is around 5 liters, right? So someone who is losing more than that, of course, like 2 liters or more than that, it is like grade 4 hypovolemic shock. Okay. So of course the blood pressure will be reduced, heart rate will be increased, and all those things will be there, right? Okay. Other than that, there is one shock is called as cardiogenic shock. Okay, you can see over here the example. Now cardiogenic, as the name shows, like cardiogenic means like when the origin is from the heart, right? So now what is the function of the heart? The heart functions as a pump. And what helps, like what is the thing which helps the heart to pump is basically the cardiac muscles. Now what happens is when the heart cannot pump the blood to the tissues, we call this thing as cardiogenic shock. You can see a 55-year-old male with history of hypertension, diabetes mellitus, present with crushing substernal chest pain, like sweating, hypotension, tachycardia, and cool, clammy extremities. So now, remember myocardial infarction, like what we call it as heart attack, or for example, someone who have cardiac arrhythmias or someone who have any type of cardiomyopathy. So what happens is like the heart cannot pump enough blood. And when the heart cannot pump enough blood, so the blood cannot reach to the tissues, or you can say less blood is going to reach to the tissues, and what will happen? Again, the tissues will be hyperperfused or will be in the state of shock. And when the origin is from the heart, we call it as cardiogenic shock, right? So, again, like this is defined as the systolic blood pressure less than 90, okay, and you can see over here the signs: cool skin, tachypnea, hypotension, altered mental status, narrow pulse pressure, rales and murmurs, and acute myocardial infarction, sepsis, myocarditis, myocardial contusion, aortic or mitral stenosis, hypertrophic cardiomyopathy, and acute aortic insufficiency are the examples of that. And again, the pathophysiology, like they are talking about, like when the left ventricular function is not there, of course, the blood cannot be pumped, cardiac output will be reduced, and it can result into shock, right? So that is again a type of the shock. Now, for example, like I told you, one of the things is obstructive shock, right? Now, obstructive shock, as you can see over here, in pulmonary embolism, what happens is like there's a blood clot which came and it gets stuck in one of the main pulmonary veins, right? Or sorry, arteries. So, what happens in obstructive shock? Basically, there is obstruction obstruction on the way of the blood, so the blood cannot flow, and when the blood cannot flow, of course it cannot cause cardiac filling, and uh, when it cannot fill the heart, so of course the heart practically cannot pump anything. So you can see over here, 24-year-old male presents to the ED after a motor vehicle collision, complaint of chest pain, difficulty breathing. On physical examination, you note that the patient is tachycardic, hypotensive, hypoxic, and with decreased breath sounds on the left. Now, basically, this is the example, or this is the scenario of tension pneumothorax, or it could be pericardial tamponade. Okay, so what happens is in cardiac tamponade, like uh, there is collection of the fluid around the heart, and which cannot uh, allow the heart to um, expand or to relax. And of course, when the heart cannot relax, so it cannot fill up properly, and when it cannot fill up properly, of course it cannot pump properly. Or for example, what happens in tension pneumothorax is like the air is trapped inside the pleural cavity, and that causes pressure on all the like other side of the lungs as well as on the heart, and the heart cannot pump properly. Or massive pulmonary embolism, which I already show you. Okay, in which like there is a big clot which gets stuck inside one of the big vessel, and the blood cannot flow. And when the blood cannot flow, of course the heart cannot fill up with the blood, and the heart cannot pump the blood effectively. So simply there is reduced filling of the left or right side of the heart, and simply because of that the heart cannot pump properly. Or one more example is aortic stenosis, in which the valve is so much narrowed that it cannot allow the blood to pass through that valve properly, right? Now maybe there will be a question in your minds. Basically, there was a question in some other student's mind last year, that if aortic stenosis or pericardial tamponade, why they are not included in cardiogenic shock, but rather obstructive shock. Remember one thing, that in aortic stenosis or pericardial tamponade, there is nothing wrong with the cardiac muscles. The problem is not intrinsic to the heart, not cardiogenic. It is some sort of obstruction in which the heart muscles are completely fine, provided you are going to remove that obstruction. Once you are going to remove that obstruction, what will happen, that the blood will start flowing and the things will become normal. Okay, now what I'm going to tell you about, or what I'm going to talk about, is basically um, a type of shock which I include in my list, that is called as distributive, right? Now, distributive shock basically is a condition. What happens is like the circulating volume is normal, it is not reduced, but what happens is like the circulating volume is there, but the intravascular space is so much widened or so much expanded, that the circulating fluid which is, or the volume which is inside the intravascular space, now it have a lot of space, so that's why there is no effective perfusion. Okay, for example, there are different type of distributive shock, like septic shock, okay, like anaphylaxis. Okay, so what happens in these patients is like there is vasodilatation, and because of vasodilatation there is low systemic vascular resistance, and because of that there is inadequate afterload, and because of that, the tissues cannot perfuse much. What happens in anaphylaxis is basically There is release of histamine, which basically causes vasodilatation. What happens in septic shock is basically there is release of some toxins which causes vasodilatation. So simply, in simple words, the blood volume is enough, but what is the problem is that in these patients there is like the circulating like the intravascular space is too much expanded, or you can say too much so that the blood cannot circulate properly. So these are the types of distributive shock, and that's why I remove anaphylaxis and uh, anaphylaxis and septic shock, right, in these categories. So you can see over here the example of septic shock. An 81-year-old resident of a nursing home presents to the ED with altered mental status. She is febrile, hypotensive with widened pulse pressure, tachycardia with warm extremities. So it can result due to systemic inflammatory response syndrome, which we are going to cover in the coming lectures. And it is one of the type of the shock in which the peripheries of the body, instead of going cold and clammy, can become warm. Okay. So this thing, of course, like I'm going to discuss in the coming lectures, like we will study this SIDS and MODS in great detail. So you can see like the organism, and it causes systemic inflammatory response, and there is damage to the endothelial cells, and because of that endotoxin is released, they damage that, and global tissue hypoxia can occur. Okay, so other than that, one of the thing is anaphylaxis, which is also a type of distributive shock. And you can see a 34-year-old female presents to the ER after dining at a restaurant, where shortly after eating the first few bites for her meal become anxious, diaphoretic, begin wheezing, noted diffuse pruritic rash, nausea, and sensation of her throat closing off. She is currently hypotensive, tachycardic, and ill appearing. So anaphylaxis, as I told you, like there is too much histamine released. That's what happened when someone is bitten by a bee, honeybee. So they can go into anaphylactic shock. So it is IgE mediated. It could be non-IgE mediated. And these are the symptoms and signs of that anaphylactic shock. Okay. So this is about distributive shock, and then there is endocrine shock. Okay. So what is endocrine shock is basically endocrine shock is, you can say, it's a combination of hypovolemic, cardiogenic, as well as distributive shock. Okay. For example, what happens in hypo or hyperthyroidism or adrenal insufficiency? In hypothyroidism, what happens is like there is disordered vascular and cardiac responsiveness to circulating catecholamine. So that's because of that, cardiac output decreases, and the patient can go into bradycardia. And in thyrotoxicosis or hyperthyroidism, there is high output cardiac failure. And same thing happens in adrenal insufficiency when there is hypovolemia. One of the shock is neurogenic. As I told you, neurogenic. Okay, neurogenic, for example, someone who get a spinal cord injury. So neurogenic, of course, is, you can say, is a type of, as I told you before, it's a type of distributive shock again, right? Anyone who have a road traffic accident, what happens is like, due to a spinal cord injury, they can go into this type of shock. Okay. Like in high spinal injury, basically there is failure of sympathetic outflow, and once there is failure of sympathetic outflow, basically these patients, they develop or they go into abnormal, or you can say inadequate vascular tone, which can result into distributive type of shock. So C occurs after acute spinal cord injury, sympathetic outflow is disrupted. So neurogenic shock is a type of distributive shock as well. Results in hypotension and bradycardia. Okay. So loss of sympathetic tone results in warm and dry skin. Shock usually lasts for 1 to 3 weeks, and after that, it comes back normal. Okay. So like these are the different type of shocks which I told you I was discussing with you. Now the point is like whenever anyone comes in shock, what we do, of course, we do a quick physical examination. We check the vitals, we check the blood pressure, pulse rate, temperature, urine output, respiratory rate. All the things are level of consciousness is very important, because if there is altered level of consciousness, so it means like that there is decreased cerebral perfusion as well. So anyhow, like depending on that, we discuss like, or we decide whether the patient is in mild shock or moderate shock or severe shock. Okay, like for example, someone whose urine output is normal, respiratory rate is normal, pulse rate is only mildly increased, so it means like the body is still compensating. But of course, when someone uh, uh, will lead to, for example, if someone is left in that situation for a long period of time, or is not provided with any help. Okay, like as I told you, like level 3 and level 4, or grade 3 and grade 4 shock, in which the patient is losing 30% or more of that the circulating volume. So of course what happens is the body perfusion cannot be maintained anymore. So how we deal with the patients of shock? Okay, generally I'm not going to discuss each and everything, rather I will quickly go through the approach to the patient, right? So what we have to do, you can see over here, like recent history should be taken by, because see, you are checking either it's a septic shock, it's a distributive type of shock, it's an anaphylaxis, it's neurogenic, it's hypovolemic, it's endocrinal. History taking is very important. You will look for fever, you will look for any insect bite, you will look for any prior illnesses, you will look for any road traffic accident and everything. We go for the physical examination, we can take the vitals as I told you, we check the mental status, examine the skin, check the JVP, check the capillary refilling time, and all the things. Of course, because we have to grade the shock as well. What type, what severity of shock there is. The shock can be mild, the shock can be moderate, the shock can be severe, the shock can be hypovolemic, the shock can be distributive, the shock can be cardiogenic, the shock can be distributive, the shock can be endocrinal. Of course, these answers you will get according to the history and examination you will do. Without that, you cannot reach further. And based on that, you are going to send the labs like CBC, chemistries, lactate, coagulation studies, cultures, or ABGs, whatever is required, depending on what type of shock it is. Or you can go for a CT scan, lumbar puncture, wound culture, CT, ultrasound, whatever like is done. Okay, so now what is the goals of the treatment, or how we manage? Of course, whenever any patient comes to us, the first thing we do is like we start resuscitation. And how we start resuscitation? Remember, ABC approach is the important one in emergency: airway, breathing, and circulation. You will see that you will control any ongoing hemorrhage, which is very important, because if someone is losing blood, and even if you will start providing them blood, the condition will not become better until unless you will stop the bleeding. So, for example, if we are going to treat a patient with hemorrhagic shock, so what is the important thing? The first thing is secure the airway, control the source of blood loss, like breathing, and of course, we have to give them IV resuscitation, right? So, if we are going to discuss the resuscitation, what is the first thing to do is after stopping the bleeding, we maintain the IV cannulas, right? So airway, breathing, circulation, right? Provide them oxygen, of course. So the most important thing to understand in hypovolemic shock is fluid resuscitation. And what kind of resuscitation? Of course, if someone is losing blood, so providing blood will be the most useful thing you can do to them, but blood are not available all the time. So of course you will send the call to the blood bank to arrange them. But before that, you are going to start them with IV fluids. So intravenous access is taken and IV fluids are started. We attach them with the monitors, keep on monitoring their blood pressure, their pulse pressure, their heart rate, their central venous pressure, like all the things, which are there. And as I told you in the fluids, like there is no ideal resuscitation fluid, like Ringer lactate or normal saline, any one of can be used, right? And the main aim is to what you can say, wait for the blood, because blood is the most important thing you can provide to the patient. And of course, like we do the labs as well with that. So, and a lot of drugs can be used for that. For example, we can provide them with vasopressors or inotropic support. Vasopressors like epinephrine or epinephrine, very important in distributive type of shocks like sepsis or neurogenic or anaphylaxis, right? And for example, if it's cardiogenic type of shock, we can give them inotropic support like the digoxin, simply like to increase the heart contractility, dopamine or dobutamine. Okay, so dobutamine is an agent of choice, especially in these patients. And what is done is, for example, if you are dealing with a patient who have septic shock, you are going to provide them with antibiotics, right? You have to treat that, of course. So the important thing is, of course, our goal of resuscitation is to maximize the survival and minimize morbidity. So what are the things which we can check, like either the patient is enough resuscitated or not? Lactic acid levels can be checked, of course, like because if the cells are going anaerobic respiration, lactic acid will start accumulating in the body. ABGs or VBGs, venous blood gases should be done. So one aim is to, of course, maintain the vitals: blood pressure, pulse, oxygen, all these things. So traditionally, what they do, we see the vitals, and vitals tell us the best parameter, like the urine output also, like either the tissues are getting enough perfusion or not. So if the brain is getting enough perfusion, so what it means, like the mental status will be normal. If the kidneys are getting enough perfusion, so what it means, like the urine output will be normal. If the heart and all these organs are getting enough perfusion, so the blood pressure and the pulse rate will be normal as well. And also we keep on checking the other things. For example, we can check the base deficit, we can check the lactate levels, we can check the VBGs, and we have to bring that back to normal as well. So you can see, like, goal directed approach is to maintain the urine output more than 0.5 milliliter per kg per hour, central venous pressure to 8 to 12 millimeter of mercury, mean arterial pressure we should maintain in this range, and central venous oxygen concentration more than 70. Okay, so if there is someone who is like having persistent hypotension, check for pneumothorax, cardiac tamponade, hidden bleeding, adrenal insufficiency, or medical allergy. Okay, so practically speaking, keep an eye on these patients, frequent vital signs, and let your nurses know that these patients are sick. So this thing. So remember, in hypovolemic shock, fluid resuscitation is the most important thing. Remember, in septic shock, for example, antibiotics will play more role. Any distributive type of shock, vasopressors will play more role. Cardiogenic shock, maybe you have to give inotropic support with resuscitation. Not much, of course, it can lead to pulmonary edema. Anaphylactic shock, again, inotropic drugs with vasoconstrictors like epinephrine or epinephrine with steroids and drugs like this. So you have to treat the cause, you have to maintain the vitals, you have to keep an eye on the endpoints of resuscitation. That's about the introduction of the shock. Hope you understand. I will see you in the next lecture. Thank you.